Good afternoon, everybody. For those I've not met here today, my name's Julie Moore and I'm the chair, relatively new, of HDR UK, and I'm delighted to be here today and learn so much about what's going on and what's about to be going on. I'd like to introduce our guest, Gavin Francis. Gavin is a GP in Scotland, and he's recently written a book about the NHS, which I'm going to talk to him about. Now, John got me up here under false pretenses by saying this would be a fireside chat, and it's so cold in this hall I agreed to do it to get near the fire, but there isn't a fire, so we're just here to chat. So I'm going to kick off by talking to Gavin and saying we both remember the days when the NHS was the envy of the world. It was number one for 3 consecutive sectors in the Commonwealth Fund. Now it isn't. What's happened?
Quite simply, there's been a series of factors come together, the strongest one being a change in political direction of the country and a gradual flatlining of the funding that has gone into the NHS over the last 12, 13 years. And that's been combined with a kind of lack of care and attention to workforce planning and a kind of a paradigm shift, really, in how healthcare is valued among the planners and organisers and governors of the country.
We're all here today working in research and data, but it is about health and it is about the health service.
Yeah.
And we know it's a system under pressure, and a system under pressure finds it hard to do additional things.
Yeah.
Your book's about a defence of the NHS. Why do you think it's necessary to defend it?
I think the NHS is right now in need of a great deal of defence. It's far more in need of defence right now than it was, for example, in the early 90s or the mid-90s. I qualified in medicine in 99, and so I can remember still when I was a medical student that feeling the NHS that was happening round about the early to mid-90s. People were feeling this can't go on, this level of underfunding, something's got to change about the way we approach healthcare in this country. And then in 97, when I was in fourth year medical school, there was a change in government. And so when I qualified and was a junior house officer in 99, 2000, there was a real sense then that healthcare was back centrally placed in the priorities, both of the people of the country, the voters, and also government. Government was very interested in healthcare by prioritising it. And that feeling of central priority is not there anymore. It's not there at all. And that's why we're seeing, for example, these are figures from 2019, so before COVID. 2019 NHS England was short 43,000 nurses at 110,000 vacancies unfilled. 2,500 midwives were short. So it's quite extraordinary that any system is able to function at all with 110,000 vacancies in the workforce. So my own view is the NHS does need defending right now. There's a lot of people who would rather the NHS didn't exist. They would rather we have a different system. We could have a system like the French or the Germans say. We could involve a level of insurance payments. But if we were to move to that system, there has to be a sort of, we have to be open with the electorate that that's what we want to do. It has to go into a manifesto and we have to get the chance to vote on it. That hasn't happened. So what we're seeing is just the gradual degradation and diminution of the service caused by a kind of willful neglect, I would argue.
So a lot of the argument we hear now is that it's all to do, the problems are to do with COVID and it's to do with the doctors' strikes.
Yeah, no, that's completely false. I mean, you can see you're all data whizzes here. You can just look at the graphs and you can see that all these problems were there long before COVID. Waiting lists, for example, were going up and up and up long before COVID. And the figures that I've just given you, they were all from 2019. So the situation is worse now.
So how can we solve this? I remember I started my career as a nurse in the NHS, and I can remember the sense of hope. But it took a while before any additional funding could help. What could we do now? If a new government came in and said the NHS is the priority, do you think it could turn it around in 3 years?
Yes, I think so. I mean, right now, the NHS is always going to be a bone of contention, and in a healthy democracy, that is a good thing. It's a good thing that we should have robust debate about what our priorities are as a country, and it's a good thing that we have people who have very different ideas about how we should fund a national health service or how we even implement a national health service, arguing it out. But what we don't have at the moment is a degree of sort of transparency and honesty about the discussion. And I would much, much rather see us have a far more open and reasoned debate, in particular about the workforce. So you mentioned the recent junior doctor strikes. Some junior doctors were putting their pay slips on Twitter, and I was shocked to see a FY doctor put his pay slip on Twitter, and he was getting paid the same as I was paid in 1999. So there's been a very real degradation and diminution in the value that we place on that workforce. We were happy 2 or 3 years ago to encourage that workforce by clapping for them on the doorsteps on Thursdays, but now we're not prepared even to pay them what they were getting paid in 1999. The same goes for nurses. Nurses' pay has also dropped 20%.
So if we suddenly had a new plan tomorrow that we're going to turn the NHS around, it takes a long time to train doctors, so how are we going to staff it?
Well, right now, we're not even retaining the staff that we have. So we could start by thinking some innovative ways of retaining staff. The staff are feeling quite burnt out, quite neglected. They've had a very difficult time. Often, many of them were quite traumatized by working through COVID. And it would be quite easy, I think, if there was a change of priorities at the top to show that workforce some love, show them some appreciation. At the moment, that's not what we get at all. We just get the corridors of power tend to imply that junior doctors, for example, are being greedy and selfish. Nurses and nursing training is not being encouraged or promoted. It's very difficult, actually, at the moment to try and stay within the workforce if you're keen and enthusiastic to do so, because the working conditions are so hard. I was on the phone recently to an occupational therapist whose job is absolutely fundamental in helping frail elderly people get out of hospital and back home. And this particular occupational therapist told me that she couldn't help me. I would have to admit my patient to hospital because there was supposed to be 4 people in her team and she was working alone. So her team was running on a 25% capacity. How can we deliver good, effective healthcare where you've got a 25% capacity in the workforce? It's just extraordinary. So we need to reverse that. We need to show the workforce that they are the NHS's greatest asset and put the plug back in the bathtub of staffing, because right now so much of it is draining away through people finding other work and through early retirements.
I mean, you've made an important point there that actually when you get a shortage in one area, it knocks onto another. It's like you're poking a balloon down in one a bubble in a balloon down, it pops up elsewhere. Yeah. So that was another hospital admission. Yep. Presumably when that patient was ready to discharge, we have the same problem, not enough OTs and physios in community for people to come out, so it's a false economy.
Yeah, absolutely. It becomes it becomes very difficult to get people out of hospital and into the community. And perhaps we could talk as well about primary care. So primary care, it's wonderful in terms of the data that we hold in primary care, and most of it is held within a couple of different programs that do make the amassing or the extraction of that data possible. But primary care, as you probably know, sees 90% of the encounters in the NHS, but it does it with about 8% of the funding. And so the pressures on primary care are going up and up and up. And when people can't get into hospital, they're told to see their GP instead. But that environment of the primary care clinic is getting harder and harder, which is why many of you, when you do phone for a GP appointment, are probably told, phone at 8 o'clock and just try. You know, that is not a functioning system. That is a broken system when you can't actually get an appointment to see a primary care clinician when you need one.
And how about the model of general practice? I've heard so much about GPs going abroad to Canada, to Australia and that. How is staffing in general practice at the moment?
Yeah, it's very difficult. So about a third of junior doctors right now are going to Australia and New Zealand. Some are coming back, but the pay and conditions are just so much better there. And if we want to think about a market in healthcare. There's a very obvious market in trained professionals. And right now the market is pulling them to Australia and New Zealand in quite huge numbers. In general practice, yeah, we're seeing similar problems. I mean, regularly in my own city, I practice in Edinburgh, they're advertising for partner jobs and there's 0 applicants, like no applicants for a job in the city centre of Edinburgh. It's quite extraordinary. So yeah, there's a real problem, and it's been years and years of very kind of careless workforce planning has led us here.
And we've heard a lot about the capital estate, the hospital buildings and the equipment, and the buildings in particular. Some of them came to the light with having reinforced aerated concrete or whatever it is, but we've not invested in capital. Is that the same in primary care as well?
Yeah, primary care, it's a very odd situation, as some of you may know, in the sense that when general practice was brought into the NHS in 1948, general practitioners were left as essentially independent contractors who bill their local health board for services essentially as small business people. And that means there's incredible heterogeneity of the primary care premises. Some of them are still in the old doctor's house. Some of them are on very sort of strange lease agreements for a certain number of years. And it would be wonderful to bring that up to date. I read a recent statistic from the King's Fund that we're now about £9 billion a year shortfall in the capital investment of NHS estates. £9 billion a year. That's gradually happened over the last 10, 12 years as well. As money that was meant for capital maintenance has been gradually diverted into the provision of frontline services.
And that again has a knock-on effect when you have infections and you haven't got the facilities to isolate people. So it adds to the spiral of demand and pressure on the staff as well.
Yeah, very much. And that's why I keep coming back to, I think workforce is the most tricky challenge to be faced up to. It's just, if you can help staff feel like they come to work and do a good job rather than leaving their at 5 o'clock or 6 o'clock exhausted, demoralized, and feeling they're not able to live up to the standards of the training that they aspire to, then we need to find a way of reinstilling people's love of the work, because clinical work is hard, as you all know. It's difficult, it's emotionally difficult, but it's also immensely rewarding when you can do it in the right environment, when you feel supported.
And what about the introduction of new drugs? We read about brilliant innovations in drugs that are going to cost a phenomenal amount of money, and yet are we able to implement that in the NHS now?
So the primary care budget for this country is £180 a person a year. So to get access to a GP is 50p a day for all of you. You pay 50p a day so that you can have a GP. The drugs budget for the NHS right now is £350 a year. So it's about double the primary care budget. And what we're seeing now, we are seeing incredible pressures on the drugs budget in the NHS because of this magnificent revolution in drug design that's happened over the last few years. I'm sure many of you know all about biologic and specifically targeted drugs, which often cost upwards of £10,000 per patient per year. And that was manageable within the framework of NICE. I mean, I'm sure you all know about NICE, National Institute of Clinical Excellence, that sets the price bar for the NHS of a new drug at between £20,000 and £30,000 a year per quality added life year, so per QALY. So if a new drug costs £25,000 per person per year, but adds in terms of quality of life and years added, it will be approved. But that was fine when there was only a few of these drugs. But now we're seeing biologic drugs for all sorts of conditions, for osteoporosis, for migraine, for more and more autoimmune conditions. And they're magnificent, some of these drugs. But if we're going to have them all, we need a bigger drugs budget. So I would argue that we do need a national urgent conversation about what is good enough medicine. What are we prepared as a nation to pay for? How expensive a drugs budget are we prepared to pay for? Because the old NICE guideline of £25,000 per person per year with these new drugs that are coming online is just not affordable under the current settlement. And Simon Stevens said in 2017, so 7 years ago now, he said the NHS is no longer funded to do what the politicians or the voters are asking of it. So we're 7 years into a red deficit in terms of budget.
Do you think that this is a conversation that's been brushed under the carpet because it's too difficult, both from us as professionals and also from politicians, that actually we need to be far more upfront with the public about if you need the top of the class health service again, then it's going to cost more?
Yeah, I do think so. And I mean, that's exemplified by, I read Jeremy Hunt's memoir recently about his 5.5, 6 years as health secretary. He's the longest serving health secretary the last 100 years. And he states quite candidly in his memoir that he set up a separate fund for rare, expensive cancer drugs, for the kind of situation that sometimes ends up on the front page of a tabloid and is very difficult for a politician if somebody has been refused a particularly expensive new cancer drug. But in order to set up that fund, he had to take money from other frontline services. And I think that exemplifies how services, particularly mental health services, are continuously neglected because they don't make it onto the front pages. But other kinds of far more potent political electoral issues do get pushed up the agenda and reprioritized. And I would like to see far more honesty with the public about the true costs of 21st century medicine and a reframing of the conversation about back to us as the voters. You know, it's up to us, it's our NHS. What kind of NHS are we prepared to pay for?
We are a conference today about data as well. How do you think the use of health data could help us deliver more effective, efficient health services?
Hey, in so many ways. I mean, just the way that we can mine data to find better ways of early diagnosis before very expensive interventions are necessary, to find better ways of managing people in the community with complex health conditions and multimorbidity without them having to go into hospital. I would like us to see more data. I know I keep going on about workforce, but I would like to see more analysis of how we keep people in the workforce. What are the factors of a good, satisfying, rewarding workplace? You know, why are we not seeing that replicated around the place? It's always about the patients, but we're in such a dire state right now in the NHS that we need some focus on maintaining and supporting the actual clinicians.
Okay, so having heard all that you've got to say and read your book now, I am now going to, in the next election, make you Secretary of State for Health. What are you going to do in your first 100 days? Okay,
first I'm probably going to go to number 11 Downing Street, straight off, and I'm going to say, for too long we have had a budget health service. Let's look at the French, look at the Germans, look at the Dutch. What do they spend on health? And let's agree to benchmark our healthcare on our nearest European neighbours. Of course, we could half the NHS budget and we could just have a very poor NHS. It's up to us to decide at what level we want to pitch that. So I would first argue that we need adequate funding. If we want to keep up with our neighbours, we need to spend like our neighbours. And then in my first 100 days would be about workforce, because the workforce really need to feel some support and that they are cared for and valued by the people above them. So I would find ways of boosting workforce, increasing medical school places. That work started, but it needs to be expanded. Nursing places, bursaries for nursing. I don't think people who are going into nursing or who are wanting to retrain to go back into nursing should have to pay any fees. If we've got 43,000 vacancies, why are we having to ask people to pay in order to retrain to come and help the National Health Service? So those are some priorities that I would have in my first 3 months.
I read only last week that the doubling of medical school places had been withdrawn and it wasn't going to happen. Is that right?
I'm afraid, because I work in Scotland, in Scotland we've increased them by 50% or so, and that's sustained. So I don't know if that has been cancelled.
I mean, I'm going to just break the rules here now and say that I was told that to train a medical student costs between 250 and 500,000 a year. It's too expensive. The cost of an agency doctor for 1 year in a hospital is close to that. It's a false economy not to train more. she said, moving away from the questions. Sorry. It's been a real agony for me not to get my own point of view in here. Is there anything else you want to say before I open it up to questions and let other people have a word?
No, I'd like to let the questions come.
Okay.
If we've got any.
Have we got any questions? Yes, we have. From Emily Murray. Does the UK have any programmes where student loans of NHS staff will be waived if they work in a location of severe shortage for a contracted period of time?
No, that I'm aware of.
Nor me.
I've never heard of that.
It's a really good idea, and Emily Murray, I make you Deputy Secretary of State for that one as well now. From Amit Bakai, has workforce work enjoyment reduced as we digitise the NHS? Has the enjoyment of the workforce, their enjoyment of the work got lower because of digital systems?
It depends. It depends. That's a very politician's answer. In some ways, IT definitely helps. It frees up my time. To be able to, how much would I love, for example, to be able to use a keyword to search through the correspondence of my patients' records? I can't do that. So that would be wonderful. That would free up a huge amount of my time to actually pay attention to my patient if I could search document where all their correspondence is for keywords. So some time-saving things are wonderful about digitization, but there's a kind of creep, which I think is a negative thing, where we are increasingly gauged and measured on what can be measured. So that pushes you to the computer more than you probably need to be, because your outcomes are all things that can be digitally recorded. It continually pulls you back to ticking boxes and filling things in the computer when you should be looking at the patient. So I would say it depends.
Are there any questions from yes? Can somebody... There's lots of people coming around with microphones, so... Oh, have you got one? Yes, sir.
Yeah, hi, Emma Gordon, Director of Administrative Data Research UK, ADI UK. I've got good news for you. We've worked with the Nursing and Midwifery Council and ONS to make NMC registrant data available to researchers linked to 2021 census data for England and Wales. So we can facilitate research being done exactly as you say, understand who's leaving the professions, what their circumstances are, what their family situation is, and what the triggers are possibly for them leaving or staying. And we've got a research fellowship call out now to fund research being done on that data.
Great, thank you.
That's good news. You just need to take action on the info you get then. Thank you. Somebody else with a mic?
With a mic at the back. Right.
Okay.
Hello, over here. Hello. Over here to the right.
Oh, okay.
Hi. Sorry, maybe I should stand up. Hi. Chris Cole, University of Dundee. I'm an academic director of the Health Informatics Centre. So we run a TRE for managing patient data and for research. And as a clinician, what is it you see coming out of research that you would see the first thing you'd want to see moved into the clinic that has been done in research already?
So can you reframe? So what, as a clinician...
So there's lots of research, that, as Piers today showed, there's lots of cool stuff happening in AI especially, but this has been going on for a long time, but there hasn't been the transition into the clinic. We're still doing the same things in the clinic that has been done for forever. So what is one thing that you've seen in research you think, kind of like saying, doing a Google of your patient correspondence, what is another thing that you would see that make a real difference to you as a GP?
It's difficult in the current resource envelope because the days are so pushed and stressed that there's not about a little bit of extra time. But, for example, I did recently read a paper that was looking at analysing attendances for different mental health issues and showing that AI was used as a way of predicting diagnoses of bipolar illness, presentations later. So there were certain patterns that were emerging in terms of presentations to general practice clinics with various mental health problems that turned out to be mildly but weakly predictive, which I thought was a fascinating way of thinking about how we can use AI if you can sweep the entire GP record of the nation for patterns of presentation and then start to elucidate very unusual constellations of presentations which then lead to later, more significant diagnoses. That would be a wonderful thing to be able to do with data.
And I would just add, having worked with the big bunch of GPs, pinprick blood tests for a much wider range of things would solve a lot of problems instead of blood having to go off to hospitals and labs all over the place. That's just my view. Some more questions? Have some more hands? There's one over there.
One here,
yeah.
Johnny Pearson, HS England. Often to make my work useful for yourself, I need to get GP or clinicians' input into it. Have you got any comments about how I can get your brain in a machine-readable format? Or any clinician's insight into our data work?
Well, I understand that it's quite tricky sometimes to persuade patients to give free access to all of their data to many data researchers. And I would argue that if there's enough reassurance from the patients that this data is not only anonymized, but it's going to be used to improve the service, not just for them, but for other people, rather than have that data sold to other companies. I think a lot of the reluctance to freely offer up their data that comes from people is this fear of privatization, or rather commercialization, which is a better word for it.
Another online question from Louisa Nolan. More money is needed in our health service, but money is not the only thing. What else does the NHS need to be effective? I mean, there's so many different things. There's so many different things have started to crack and crumble. You mentioned the estates and the capital investment. Workforce, we've talked a lot about. I think that we need to remember, does any of you remember reading about Finland's experiment with education? So Finland did this thing with education where they just massively increased the salary of teachers, and they placed education really centrally in their culture and in their economy, and they tried to encourage really good teachers into the system, and they made it a high prestige profession. And of course, 5-6 years later, they started churning out these wonderful educational outcomes. And that's what we need. We need a change of culture, I think, back to where we were maybe 15, 20 years ago, where health was prioritized as a nation. We did think it was important as a country to invest in that. And then all the other wonderful things will follow. There were some more hands up before. Is there any more left? Yes, one down here. You've got a mic.
Thank you. We've heard quite a lot today about bits and pieces of exciting research relating to, I guess, the prevention agenda. So we're talking about people getting sick and coming to you or ending up in hospital, but what research is needed to prevent that in the first place? But I'm very interested to hear your reflections on the role of primary care in particular in prevention and ill health prevention, and whether you think that primary care should be responsible for prevention or whether it's a wider system.
So I think primary care should be very central in a prevention agenda if it was adequately funded. So at the moment, I would argue that the system is so stressed by demand on the acute side. There's so many requests just to manage acute illness and assess acute illness that we don't actually have a lot of spare capacity as a profession, as primary care clinicians, to do that prevention agenda too. So right now, with the capacity that we have, personally, I would like to see a lot of prevention agenda moved out of the clinic and out onto radio, TV, billboards, pharmacies, if possible, because we don't have capacity. But in a well-funded primary care system, I think that we should be part of that. And indeed, when I started as a GP in 2005, that was a big part of my job under the quality and outcomes framework, the way that general practice was funded. But that's gradually just fallen away over the last 20 years as the demands to do other things and more acute reactive care have become unstoppable.
Today we've got with us some representatives of patient representatives and some charities representing different patient groups. Is there anything you could say to them how they could help in this agenda?
Yes, indeed, because I do believe that what we need is a series of possibly citizens' assemblies or an urgent national conversation, a way of actually pushing this to the top of our news agenda, rather than about small boats in the channel or culture wars, or let's put public services back to the centre of the political agenda and the media agenda, because they're in a really terrible state. And so if we start that national conversation about what our new priorities should be, then absolutely we need all the patient organisations to be central in that. That's a good example I touched on, was to do with the drugs. Do you know, what do the patient representative bodies of this country think should be a good drugs budget? Should we stick with £350 a patient per year, or should it be £500 a patient per year? Or would they prefer more time with their clinicians? So we'll cut it to £250 per patient per year, but we'll use that money to get more clinical face-to-face time with their consultant or with their GP. These are things we need the patient representatives to be absolutely at the centre of the table about.
Thank you very much. Our time is out now. So, Gavin Francis, author and GP, can I thank you very much for coming today?
Thank you.